Okay, let's unpack this. Have you ever considered the hidden battles waged within our own bodies? Or, how seemingly common viruses can hold such incredibly complex secrets, sometimes lying dormant for years before reemerging? Today, we're embarking on a deep dive designed to bring you the kind of detailed insight that transforms mere knowledge into true mastery. We really want to give you a real edge in understanding these intricate medical topics. We're taking a magnifying glass to Chapter 193, Varicella-Zoster Virus infections from a leading medical text. But before we get to the familiar territories of chickenpox and shingles, our source actually opens with a crucial look at another pervasive viral challenge, one that offers vital lessons in viral control: herpes simplex virus, or HSV.
Indeed. Our mission today is to thoroughly dissect every concept within this chapter, really get into the weeds. We'll begin by using HSV as a lens to understand the broader, often surprising challenges of viral control at a population level. Then we'll transition into a truly comprehensive exploration of Varicella-Zoster virus, delving into its origins, its remarkable journey through the body, its varied impact on individuals, and critically, how we diagnose, treat, and most importantly, how we prevent it. This isn't just about accumulating facts, it's about connecting dots, grasping the nuanced why, really understanding the profound implications these viruses have for public health and, well, individual well-being.
Whether you're preparing for a critical meeting, catching up on the latest medical advancements, or just insatiably curious about the microscopic world that impacts us all, get ready for some serious aha moments. This deep dive is crafted to leave you not just well-informed, but with a deeper, more profound sense of awe for the biological intricacies, that define our ongoing dance with these tiny yet powerful foes. By the end, you should feel a true mastery of this information, much like the elite professionals in the field. That's the goal. So let's jump right into the fascinating complexities our source reveals from the very beginning. It highlights that efforts to control herpes simplex virus disease on a population level through strategies like suppressive antiviral therapy or large-scale educational programs have actually been quite limited. That's a surprising statement for such a common virus. Why is achieving population-level control so challenging for HSV?
That's a crucial question, and it really sets the stage for understanding viral dynamics, doesn't it? The challenge isn't just about finding effective treatments, it's about the very nature of HSV itself. First, there's the issue of asymptomatic shedding.
Ah, right.
People can transmit HSV even when they have no visible lesions or symptoms, none at all. This makes it incredibly difficult to identify and interrupt transmission chains. I mean, you just can't tell who is shedding the virus by looking. Second, there's the stigma associated with HSV, which, can lead to underreporting and reluctance to seek testing or disclose status.
Yeah, that definitely complicates public health efforts.
Absolutely. Third, achieving widespread behavioral change like consistent condom use or abstinence during outbreaks across an entire population it's a monumental task. It requires sustained education and outreach, a huge effort. And finally, the absence of a highly effective, widely available vaccine for prevention at the population scale means we're largely relying on individual behavioral and therapeutic interventions, not a universal protective measure. It truly highlights the difference between treating an individual in a clinic and managing a pervasive public health challenge.
That makes perfect sense. It's a multi-layered problem then. So if population-level control faces these inherent limitations, what can individuals do? Our source immediately delves into prevention strategies, starting with barrier contraception. It points out that things like condoms decrease the likelihood of HSV infection transmission.
Exactly. The available data strongly suggests that consistent condom use is an effective means of reducing the risk of genital HSV-2 transmission. And what's particularly important, as you mentioned, is their effectiveness even during those periods of asymptomatic viral excretion. Think of it like this. Even if there are no visible signs, the virus can still be shed from the skin, and condoms act as a physical barrier against that.
Right.
However, and this is a critical caveat, condoms are not a foolproof solution. Not entirely. Despite consistent condom use, HSV infection can still be transmitted by direct skin-to-skin contact, especially when visible lesions are physically present. So while it's a powerful tool, it's not an absolute guarantee in every single scenario.
Right. Beyond barrier methods, the source also discusses chronic daily antiviral therapy, specifically mentioning valacyclovir. It says it can be partially effective in reducing the acquisition of HSV-2, particularly among susceptible women.
Precisely. This therapy offers a significant individual layer of protection, especially for women who might be at higher risk. However, our source highlights a gap in our knowledge. There are currently no comparative efficacy studies directly pitting valacyclovir against condom use.
Really? No head-to-head data?
No, not directly comparing them for prevention efficacy. This means we don't have definitive data to declare one single method better than the other for prevention. Because of this, and recognizing the limitations of each approach on its own, most medical authorities actually suggest utilizing both approaches concurrently.
Ah, combining them.
Yes, for optimal prevention. This multi-pronged strategy acknowledges the diverse ways HSV can be transmitted and aims to maximize protection by combining different layers of defense.
So when we look at the entire landscape of HSV control, what's the ultimate pressing need that emerges from this discussion? What's the big takeaway?
Well, the source clearly underscores a critical overarching need, a truly effective vaccine to prevent HSV infection altogether. That's the holy grail, really. And if we connect this to the bigger picture, this need is amplified by a profoundly important connection. HSV-2 plays a significant role in enhancing the acquisition and transmission of HIV-1.
Wow, okay, that's a huge connection.
It is. It's a crucial, often overlooked insight. Think about the global fight against HIV. An effective vaccine for HIV wouldn't just tackle herpes. It would have significant ripple effects, potentially slowing the spread of HIV by reducing one of its key cofactors. So the search for an effective HSV vaccine isn't merely about preventing inconvenient symptoms, it's about making a major impact on another, even more severe global public health challenge. It's a prime example of how seemingly distinct health issues are deeply interconnected.
It's a powerful connection that really highlights the complex web of viral epidemiology. The chapter also brings up a particularly vulnerable population where prevention is paramount: newborns. It states that a substantial portion of neonatal HSV cases could actually be prevented. That's a stark statistic, isn't it?
It truly is, and understanding the mechanisms behind neonatal infection is key to prevention. Neonatal HSV infection can result from two primary scenarios during birth. First, there's the acquisition of maternal infection near term, meaning the mother contracts HSV for the first time late in her pregnancy. This is often the most severe scenario for the newborn because the mother hasn't had time to develop antibodies to pass on.
Right, no passive immunity yet.
Exactly. Second, it can occur from the reactivation of infection at delivery in an already infected mother. In this case, the mother has latent HSV that becomes active just as the baby is being born. These are distinct situations that demand different preventative strategies.
So what preventative measures are recommended for pregnant women to protect their newborns? What's the behavioral counseling aspect?
Behavioral counseling forms a critical cornerstone of prevention. For women without known genital herpes, the strong recommendation is to abstain from vaginal intercourse during the third trimester of pregnancy, especially if their partners are known to have or are suspected of having genital herpes. This is a direct behavioral measure designed to reduce the risk of a primary maternal infection occurring late in pregnancy, which, as I mentioned, poses the highest risk for the newborn.
And what about antiviral therapy in late pregnancy for women who are already infected with HSV-2? Is that a widespread recommendation?
Well, some authorities have indeed recommended antiviral therapy, specifically acyclovir or valacyclovir, for HSV-2 infected women in late pregnancy. The goal here is to reduce the frequency of HSV-2 reactivation around the time of delivery, thereby lessening the chance of the baby being exposed to the virus in the birth canal.
Okay, that makes sense conceptually.
It does. However, and this is where the public health strategy becomes nuanced. Crucially, data are not available to unequivocally support the efficacy of this specific approach as a widespread public health strategy.
Ah, okay, so the individual benefit versus population strategy is tricky.
Exactly. The high treatment to prevention ratio, meaning a large number of women would need to be treated to prevent a relatively smaller number of cases, makes this a difficult and perhaps, from a population-level cost-benefit perspective, a dubious strategy. But despite these public health challenges for broad implementation, it can reduce the frequency of HSV-associated cesarean delivery for the individual woman.
Which is a tangible benefit for her.
It is. This really emphasizes that medical decisions, especially at a population scale, involve complex trade-offs and rely heavily on robust data beyond just individual clinical benefits.
It's fascinating how, even with common, well-understood infections like HSV, the path to widespread population-level control is so nuanced, and sometimes fraught with unanswered questions or pragmatic limitations. It really underscores the intricate balance of viral biology, human behavior, and public health infrastructure. Okay, now let's shift our focus to the main subject of Chapter 193, Varicella-Zoster Virus, or VZV. Our source clearly defines VZV as the singular cause of two distinct clinical syndromes. What are these two very different manifestations?
Precisely. VZV is the clever virus responsible for both varicella, which we commonly know as chickenpox, and herpes zoster, or shingles. Varicella is described as a ubiquitous and extremely contagious primary infection, typically a benign illness of childhood characterized by a distinctive vesicular rash all over the body. Herpes zoster, on the other hand, is a reactivation of that same latent VZV.
The same virus reappearing?
Exactly. Most commonly occurring after the sixth decade of life and presenting as a localized unilateral dermatomal vesicular rash following a nerve path. So think of it as one virus with a dual nature, a youthful, widespread attack, and a later life localized reemergence.
That's fascinating. A single virus responsible for two such different diseases. It truly feels like a medical detective story, doesn't it? Our source details how this connection was historically and molecularly confirmed. What were the early clues?
It absolutely was a detective story, and the clues emerged gradually over time. Early in the 20th century, sharp-eyed clinicians and pathologists began noticing striking similarities in the histopathological features of skin lesions. Under the microscope, you mean? Yes. Taken from patients with varicella and those with herpes zoster. When they looked under the microscope, the cellular damage and inflammatory patterns in the skin looked remarkably alike, despite the different rash distributions. That was the first hint. Then, when viral isolates from patients with each disease were grown in tissue culture, they produced similar cellular pathology. Specifically, they both showed the appearance of eosinophilic intranuclear inclusions, which are basically viral factories within the cell nucleus, and multinucleated giant cells, where infected cells literally fuse together.
Wow.
These biological similarities strongly suggested the viruses were closely related, but didn't yet definitively prove they were the same.
So those cellular similarities were a powerful indicator. What was the final piece of the puzzle that definitively confirmed the connection? The smoking gun, so to speak.
The conclusive, definitive evidence came from the advent of molecular biology techniques, specifically restriction endonuclease analyses of viral DNA.
Yeah.
Researchers took viral DNA samples from a single patient who had experienced chickenpox in childhood and later developed herpes zoster as an adult. By comparing the detailed molecular fingerprints, the specific patterns generated when the viral DNA was cut by these enzymes, they were able to unequivocally verify that the same virus, with identical DNA, was responsible for both distinct clinical presentations.
Absolutely identical.
Yes, this was a landmark discovery that unified our understanding of these diseases and revolutionized how we approached them. It confirmed that what seemed like two different illnesses were indeed caused by one incredibly clever virus. It truly was an aha moment that reshaped our entire understanding.
So VZV is officially a member of the herpes viridae family. What does that tell us about its fundamental structure, and how does that relate to other viruses we might be familiar with, like, say, the one that causes cold sores?
Understanding VZV's family membership is quite illuminating, yeah. It immediately tells us a lot about its fundamental blueprint. Like all other herpes viruses, including the herpes simplex virus we just discussed, VZV possesses shared structural characteristics. It has a lipid envelope, a fatty outer layer surrounding a nucleocapsid, which is the protein shell protecting its genetic material. This nucleocapsid exhibits icosahedral symmetry, meaning it has 20 triangular faces, like a tiny intricate die.
Like a geometric shape.
Exactly. The entire viral particle has a total diameter of approximately 180 to 100 nanometers, making it quite large for a virus. And at its core, it contains centrally located double-stranded DNA, which is about 125,000 base pairs in length. These shared features are fundamental to how herpes viruses infect cells, replicate, and crucially, establish latency.
Ah, the dormancy ability.
Precisely. Their remarkable ability to go dormant within the host and reactivate later. It's a hallmark of the family that explains why VZV can cause chickenpox and then later shingles.
All right, let's dive into the fascinating, if somewhat sinister, journey of this virus once it enters the body. How does it actually cause a primary infection like chickenpox? What's its clever invasion plan?
The invasion plan for primary VZV infection, or chickenpox, begins quite readily by the respiratory route.
Breathing it in.
Yes. Think about it. A sneeze, a cough. Airborne droplets carrying the virus can easily infect a susceptible individual. Once inhaled, there's a subsequent localized replication of the virus at an initial, though undefined site, presumably the nasopharynx, the upper part of your throat behind your nose. From there, this initial replication leads to the seeding of the lymphatic and reticuloendothelial system.
The immune system network.
Basically, yes, the body's immune surveillance and filtering networks. This systemic spread ultimately culminates in the development of viremia, meaning the virus is now present and circulating widely in the bloodstream. It's like the virus has gained a foothold, replicated locally, and then launched a full-scale systemic assault via the body's highways.
And how do we actually see or confirm this widespread viremia in a patient with chickenpox? What's the evidence?
Well, the most obvious manifestation of this widespread viremia is reflected in the diffuse and scattered nature of the skin lesions you observe in chickenpox, the rash appearing all over the body, not just in one spot. While it's quite rare to actually recover intact, live VZV directly from the blood, the presence of viremia is routinely confirmed by the detection of viral DNA in either blood or lesions using polymerase chain reaction, or PCR.
Ah, the PCR test. That's become standard, hasn't it?
Absolutely. It's a powerful molecular method that's become the gold standard. PCR is like a molecular photocopy machine. It can take even tiny fragments of viral DNA and rapidly make millions of copies, amplifying it to a level where the virus's genetic signature becomes incredibly easy to detect and confirm.
Moving to the cellular level, what happens to the skin itself during a chickenpox infection? What kind of damage does VZV inflict there?
At the microscopic level, the characteristic fluid-filled blisters, or vesicles, of chickenpox are not just superficial. They involve both the corium and dermis layers of the skin, the deeper layers. Histopathologically, meaning when we examine the tissue under a microscope, these lesions are characterized by what's called ballooning degeneration of cells.
Ballooning.
Yeah, imagine the infected skin cells literally swelling up like balloons and then fusing together to form these odd, multinucleated giant cells. You also see eosinophilic internuclear inclusions, which are visible clumps of viral material and cellular debris within the nucleus of the infected cells. Essentially, the virus's signature on the cellular level.
Leaving its mark.
Exactly. Furthermore, the infection may even involve localized blood vessels of the skin, which can potentially result in necrosis or tissue death and epidermal hemorrhage. That makes some lesions appear darker or more severe due to bleeding within the skin.
How do these vesicles evolve over the course of the illness from being clear to eventually crusting over?
Initially, the fluid within these vesicles is typically clear. But as the disease progresses and the body mounts an immune response, that clear vesicular fluid becomes cloudy. This change is primarily due to the recruitment of polymorphonuclear leukocytes, a type of white blood cell rushing to the site of infection, along with the presence of degenerated dead cells and fibrin within the fluid.
So the immune response makes it cloudy.
Correct. Ultimately, these vesicles follow one of two paths. They will either rupture, releasing their fluid, which importantly contains infectious virus, making the patient highly contagious, or they are gradually reabsorbed by the body. This entire process, from a fresh maculopapule to a fluid-filled vesicle to clouding and then crusting, is critical to understanding the infectious period and that characteristic multi-staged appearance of the chickenpox rash.
It's truly incredible to think this virus can just lie dormant for decades after that initial chickenpox infection, just waiting for an unknown trigger. That really highlights how complex these viral interactions are within us. So for recurrent infection or shingles, what do we actually know about how that latency is broken? How does the virus reactivate?
You're right. The ability of VZV to establish latency and then reactivate decades later is one of its most remarkable and, well, still somewhat mysterious features. The specific mechanism by which latent VZV reactivates to cause herpes zoster is, surprisingly, currently unknown.
Still unknown, really?
Yes. This remains a significant area of research. However, what we do know is that during the primary chickenpox infection, the virus doesn't just cause a skin rash. It also travels along sensory nerve pathways and infects dorsal root ganglia.
The nerve clusters along the spine.
Exactly. These are clusters of nerve cells located along the spine, and this is where the virus then remains silent and dormant, truly latent for years, sometimes even for the rest of a person's life, until something triggers its reawakening.
And what does it look like in those nerve ganglia when the virus reactivates to cause shingles? Is there visible evidence of its reemergence there?
Yes, there is. When we perform a histopathological examination of representative dorsal root ganglia during an active herpes zoster outbreak, we can clearly see specific changes. There's evidence of hemorrhage, indicating bleeding, edema, or swelling, and a notable lymphocytic infiltration, meaning immune cells are flooding the area.
So inflammation in the nerve tissue itself.
Precisely. It shows the intense inflammatory response as the virus reactivates and begins to replicate within the nerve tissue itself. Importantly, while dorsal root ganglia are key, latent virus has actually been detected in various other sensory ganglia throughout the body, including cranial ganglia, which control nerves in the head and face, and even enteric ganglia associated with the gut.
Wow, so it hides out in multiple places.
Potentially, yes. This broad distribution of latent virus helps explain why shingles can appear in such diverse, specific nerve distributions across the body.
So, while the skin is the most visible battleground for VZV, can it also affect other organs, especially in individuals with normal, healthy immune systems? Is that common?
While VZV is primarily known for its skin manifestations, active replication of the virus in other organs, like the lungs or the brain, can certainly occur during either chickenpox or herpes zoster.
Sure.
However, it's important to stress that this is uncommon in the immunocompetent host, meaning individuals with healthy, functioning immune systems. When it does occur, though, the pathology can be quite severe. For pulmonary involvement, like pneumonia, it's characterized by interstitial pneumonitis and inflammation of the lung tissue itself. Microscopically, you'd observe those characteristic multinucleated giant cells and intranuclear inclusions, along with pulmonary hemorrhage.
And what about the central nervous system? When VZV impacts the brain, how does it present? And how does that differ from something like, say, HSV encephalitis?
Central nervous system, or CNS, infection by VZV leads to histopathologic evidence of perivascular cuffing. Yeah, imagine inflammatory cells, like white blood cells, literally surrounding the blood vessels in the brain, almost like a protective but ultimately damaging sleeve. This finding is similar to what's encountered in other viral encephalitides, like measles. A crucial distinguishing feature, however, is that focal hemorrhagic necrosis of the brain, which is a characteristic and severe form of brain tissue death, with bleeding often seen in herpes simplex virus, HSV. Encephalitis develops infrequently in VZV CNS infection.
Okay, so it's usually a different pattern of damage than HSV.
Typically, yes. So while VZV can affect the brain, it usually presents differently compared to HSV. Understanding these deeper pathological effects is critical, especially when considering more vulnerable patient populations, where these uncommon manifestations can escalate into life-threatening conditions.
Let's turn our attention now to how VZV behaves in the general population, particularly chickenpox. We can draw on insights from the pre-vaccine era here. Our source states unequivocally that humans are the only known reservoir for VZV. So just how contagious is chickenpox?
It is, quite simply, incredibly contagious.
Like really easy to catch.
Extremely. Chickenpox boasts an attack rate of at least 90% among susceptible or seronegative individuals. Meaning if you haven't had it or been vaccinated and you're exposed, there's a near certain chance you'll contract it. There's no particular demographic predisposition. Persons of both sexes and all races are infected equally. The virus is endemic in the population at large, meaning it's always circulating at some level. However, it traditionally became epidemic among susceptible individuals during seasonal peaks, typically in late winter and early spring in temperate zones.
The classic chickenpox season.
Exactly. This seasonality likely reflects factors like increased indoor crowding and maybe more efficient transmission during these colder months.
And what did the historical incidence look like before the vaccine? How prevalent was it in childhood back then?
Much of our detailed knowledge about the disease's natural history and incidence truly predates the licensure of the chickenpox vaccine in the United States in 1995. Historically, children aged 5–9 years were most commonly affected, accounting for a significant 50% of all cases, half the cases. Most other cases involve children 1 to 4 and 10–14 years old. What's interesting is that approximately 10% of the U.S. population over the age of 15 was still susceptible to infection.
So not just a kid's disease.
Right, highlighting that it wasn't exclusively a childhood disease, and many adults could still get it, often with more severe symptoms. The introduction of universal vaccination of children after these observations has since profoundly transformed its epidemiology, leading to a dramatic decrease in the annualized incidence of chickenpox.
So once someone is exposed, what's the typical timeline, and how long are they actually infectious? This is crucial for understanding transmission.
Absolutely crucial. The incubation period for chickenpox, the time from exposure to symptom onset, ranges from 10 to 21 days, but it is most commonly 14–17 days. Once symptoms begin, the secondary attack rates in susceptible siblings within a household are extraordinarily high, reaching 70–90%.
70 to 90%.
In a household, yes, which vividly illustrates just how contagious it is in close living quarters. Critically for public health, patients are infectious approximately 48 hours before the onset of the visible vesicular rash.
Before they even know they have it.
Exactly. This means people can spread the virus even before they realize they're sick. This infectious period continues during the time of vesicle formation, which generally lasts 4 or 5 days, and persists until all the vesicles have completely crusted over. Once crusted, they are no longer shedding infectious virus.
Let's talk about the actual clinical presentation in someone with a normal immune system. What can you typically expect? What does it look like?
Clinically, chickenpox presents as that characteristic rash, often accompanied by a low-grade fever ranging from 37.8 degrees to 39.4 degrees, 100 degrees to 103 degrees Celsius, lasting for about 3 to 5 days, and general malaise, just feeling unwell. While most experience these symptoms, some patients may develop a prodrome, a set of early nonspecific symptoms like headache or slight fever 1-2 days before the exanthem or rash appears. In an immunocompetent patient, chickenpox is usually a benign, self-limited illness associated primarily with lassitude or a general lack of energy.
What are those specific hallmark skin lesions we should look for, and why are they so unique to chickenpox?
The skin lesions are truly the defining feature of chickenpox, and they're unique because they include maculopapules, vesicles, and scabs, all in various stages of evolution simultaneously.
All at the same time. That's the key.
That is the key. This presence of lesions at different stages, some just starting, some fluid-filled, some drying up, is a key distinguishing feature from other rashes, where all lesions might appear at the same stage. These lesions evolve from flat red spots, maculopapules, to fluid-filled blisters, vesicles, over hours to days. They typically appear initially on the trunk and face, then rapidly spread to involve other areas of the body. Most are relatively small, around 5–10 millimeters in diameter, with an erythematous or red base. Successive crops of new lesions appear over a 2 to 4 day period, further contributing to that multi-stage appearance. And importantly, these lesions aren't limited to visible skin. They can also be found on the mucosa of the pharynx and/or the vagina.
Inside the mouth or elsewhere too?
Yes, underscoring the widespread nature of the internal viremia.
Does the severity of the rash vary much from person to person, or is it fairly uniform across the board?
Absolutely not uniform. The severity of the rash varies greatly. Some individuals might have very few lesions, perhaps just a dozen or two, while others could develop as many as 2,000. It's a huge range.
2,000, wow.
Yeah. Generally, younger children tend to have fewer vesicles than older individuals or adults. Interestingly, within families, secondary and tertiary cases, those who catch the infection from another family member are often associated with a larger number of vesicles than the initial family case.
Huh. Any idea why?
It might be due to prolonged or higher viral exposure within the household setting, leading perhaps to a more robust viral replication.
How does chickenpox manifest differently, and often much more severely, in immunocompromised patients? People with weakened immune systems.
In immunocompromised patients, both children and adults, particularly those with underlying conditions like leukemia, HIV, or those undergoing chemotherapy or organ transplantation, the disease can be drastically more severe, potentially life-threatening. Their lesions are often more numerous, frequently have a hemorrhagic or bloody base, and take significantly longer to heal than those of immunocompetent patients.
A much tougher course.
Much tougher, indicating a less controlled viral infection. Critically, these immunocompromised individuals are also at a significantly greater risk for visceral complications.
Meaning the virus spreads to internal organs.
Exactly. These complications occur in substantial 30–50% of cases, and alarmingly, are fatal 15% of the time in the absence of antiviral therapy. This highlights the severe impact on those with weakened immune systems and the absolute necessity of prompt intervention in this vulnerable population.
It's clear that while chickenpox is often seen as a mild childhood illness, we absolutely cannot underestimate its potential for serious complications, especially in vulnerable populations. That really emphasizes the profound importance of widespread prevention, like vaccination. So beyond the visible rash, what are the most common and potentially dangerous complications of chickenpox?
The most common infectious complication of varicella is secondary bacterial superinfection of the skin.
Bacteria getting into the sores.
Precisely. This usually happens when the characteristic skin lesions are excoriated or damaged through scratching, creating openings for bacteria. The most common culprits are typically Streptococcus pyogenes or Staphylococcus aureus, including increasingly prevalent methicillin-resistant strains like MRSA.
MRSA too, okay.
Yes. Grand's staining of the skin lesions can be a helpful diagnostic aid to quickly clarify the etiology of unusually erythematous and pustulated lesions, ensuring appropriate antibiotic treatment if bacterial infection is suspected. This helps prevent deeper skin infections like cellulitis or even sepsis.
Beyond the skin, what's the most common extracutaneous site of involvement in children? Where else does it commonly affect them?
In children, the most common extracutaneous site of involvement is the central nervous system, or CNS. The specific syndrome often observed is acute cerebellar ataxia, characterized by problems with coordination, balance, and gait, along with signs of meningeal inflammation. This typically appears approximately 21 days after the onset of the rash, rarely developing in the pre-eruptive phase.
So quite a delay sometimes.
Yes. When the cerebrospinal fluid, or CSF, is examined, it typically contains lymphocytes and elevated levels of protein, indicating an inflammatory response in the fluid surrounding the brain and spinal cord. However, it's important to note that CNS involvement is generally considered a benign complication of VZV infection in immunocompetent children. It usually does not require hospitalization, though it can be quite alarming for parents. Other CNS issues like aseptic meningitis, encephalitis, though encephalitis is rare, and vasculitis, or inflammation of blood vessels, can also occur.
And a particularly significant complication, given its historical context and the direct advice given in our source, is Ray's syndrome. Can you explain that connection again?
Yes, Ray's syndrome is a critical point of caution. It's a rare but very serious condition that can occur in children concomitantly treated with aspirin during viral illnesses, including chickenpox. This association led to a major public health advisory, which is why aspirin is now strictly contraindicated and no longer used for chickenpox or other pediatric viral illnesses.
Because of this dangerous, potentially fatal link?
Exactly. The source also notes that, other than supportive care, no specific antiviral therapy like a cyclovir administration has proven efficacious for patients with VZV-associated CNS involvement, highlighting that management for this specific complication focuses on supportive care and symptom management rather than direct viral eradication.
What about varicella pneumonia? How serious is that complication, and who is most at risk?
Varicella pneumonia is, without a doubt, considered the most serious complication following chickenpox. It develops more often in adults, affecting up to 20% of adult cases compared to children who rarely get it. It is particularly severe and carries a high mortality risk in pregnant women, making them a critical high-risk group.
Pregnant women especially.
Yes. The onset is usually 3 to 5 days into the illness, and it's associated with severe respiratory symptoms: tachypnea, rapid breathing, a persistent cough, dyspnea, shortness of breath, and fever. More alarming signs can include cyanosis, a bluish discoloration of the skin indicating low oxygen levels, pleuritic chest pain, and hemoptysis, coughing up blood.
Coughing up blood, wow.
Yes. Radiographic evidence typically shows characteristic nodular infiltrates and interstitial pneumonitis in the lungs. While resolution of the pneumonitis usually parallels the improvement of the skin rash, patients may experience persistent fever and compromised pulmonary function for weeks.
So a long recovery.
Often, yes, indicating a prolonged and difficult recovery period.
It sounds like VZV can really spread its effects throughout the body, even beyond those severe respiratory issues. Are there any other potential complications worth noting that might be less common but still significant?
Indeed, VZV can have systemic impacts, though less commonly than skin or lung involvement. Other complications of chickenpox, though generally rarer, can include myocarditis, inflammation of the heart muscle, corneal lesions affecting the eye, nephritis, kidney inflammation, arthritis, joint inflammation, also bleeding diatheses, a tendency to bleed excessively, acute glomerulonephritis, another kidney disease, and hepatitis, liver inflammation. Interestingly, hepatic involvement, meaning the liver is affected, is actually quite common in chickenpox, distinct from Ray's syndrome.
Liver involvement is common.
Relatively common, yes. It's usually asymptomatic and characterized by elevated levels of liver enzymes, particularly aspartate and alanine aminotransferases, which are markers of liver damage. So, while often silent, the liver is frequently affected, underscoring the systemic nature of the infection.
And what about the critical impact of chickenpox on newborns, especially if the mother contracts the disease right around the time of delivery? This sounds like a particularly dangerous scenario.
You're absolutely right. This is a highly concerning situation. Perinatal varicella, which occurs when maternal disease develops within 5 days before delivery or within 48 hours thereafter, is associated with alarmingly high mortality rates as high as 30%.
30% mortality, that's huge.
It is tragically high. The illness in this setting is unusually severe because the newborn does not receive sufficient protective transplacental antibodies from the mother before or immediately after birth. Coupled with their naturally immature immune system, they are left highly vulnerable to a rapidly progressing and severe disseminated infection. In contrast, congenital varicella, which presents with clinical manifestations at birth like limb hypoplasia, underdevelopment of limbs, cicatricial skin lesions, scarring, and microcephaly, a small head, is extremely uncommon.
So the timing of maternal infection is critical.
Absolutely critical. This distinction between perinatal around birth and congenital, present at birth due to early pregnancy infection, is crucial for understanding the timing and severity of risk and appropriate intervention strategies.
Let's shift now to herpes zoster, or shingles, which our source describes as a sporadic disease. How does its occurrence differ from chickenpox, and what's its prevalence like?
Herpes zoster, as we've discussed, results from the reactivation of latent VZIG from those dorsal root ganglia. Unlike chickenpox, which is typically acquired externally from another infected person, most patients with shingles have no history of recent exposure to other individuals with VZV infection.
It comes from within, basically.
Exactly. It's an internal reawakening, a consequence of the virus that has been dormant within them. While it can occur at all ages, its incidence is highest among individuals in the sixth decade of life and beyond, with a rate of 5-10 cases per 1,000 persons in this older age group.
Increases significantly with age.
It does. Data suggests that at least 1.2 million cases occur annually in the United States, highlighting its significant prevalence, particularly among older adults. What's interesting is that recurrent herpes zoster is exceedingly rare, except in severely immunocompromised hosts, especially those with AIDS.
Usually just once, then, for most people.
Typically, yes, unless severely immunocompromised, where their weakened immune systems allow for repeated reactivations.
What are the characteristic clinical manifestations of shingles? How does that specific localized rash typically present itself?
The hallmark of herpes zoster is its unilateral vesicular dermatomal eruption.
Unilateral meaning one side.
Yes, a rash of fluid-filled blisters that appears strictly on one side of the body, following the precise distribution of a single sensory nerve, or dermatome. This is almost always associated with severe pain, which can be debilitating. The dermatomes from T3 to L3, which correspond to the chest and lower back regions, are most frequently involved. A particularly concerning manifestation is zoster ophthalmicus.
The eye involvement.
Yes, which occurs if the ophthalmic branch of the trigeminal nerve serving the face and eye is involved. This condition can be debilitating and, crucially, can lead to blindness in the absence of prompt antiviral therapy.
Making it an emergency.
Absolutely.
Yeah.
It highlights the critical nature of its location and the need for immediate ophthalmological consultation.
The mystery of reactivation remains, but what are the triggers we suspect for shingles? And how does the disease typically unfold once it begins?
While the exact factors responsible for the reactivation of latent VZV are not definitively known, making it a subject of ongoing research, triggers are often associated with a decline in cellular immunity.
Immunity going down.
Right, which can be due to age, stress, illness, or immunosuppression. In children, reactivation is usually benign and less severe than in adults. However, in adults, it can be profoundly debilitating, precisely because of the severe pain it causes. The onset of the disease is often heralded by pain within the affected dermatome, which may precede the appearance of lesions by 48-72 hours.
That's the prodromal pain, right? Before the rash.
Exactly. This prodromal pain can be incredibly misleading, making diagnosis difficult until the rash appears. An erythematous maculopapular rash then evolves rapidly into those characteristic vesicular lesions, forming a clear band along the nerve pathway.
How long does the disease typically last in a normal host? And importantly, is it possible for someone with shingles to transmit chickenpox to an unexposed individual?
In a normal host, the lesions may remain few in number and continue to form for only about 3 to 5 days. The total duration of the disease, from onset of pain to resolution of the rash, is generally 7-10 days. However, it may take as long as 2 to 4 weeks for the skin to fully return to normal and even longer for the pain to subside. Crucially, yes, patients with herpes zoster can transmit the infection to seronegative individuals.
Okay, so they are contagious.
They are, but it's important to understand the outcome. It results in chickenpox, not shingles directly.
Ah, the person they infect gets chickenpox.
Correct. The virus shed from the shingles lesions is the same VZV that causes primary infection. There's also a fascinating, though rare, entity called zoster sign herpetica.
Shingles without the rash.
Exactly. Where characteristic localization of pain to a dermatome with serologic evidence of herpes zoster has been reported in the absence of any visible skin lesions, making diagnosis incredibly challenging for both the patient and clinician.
What about when those critical trigeminal nerve branches in the head and face are involved, leading to lesions on the face or in the mouth? That sounds particularly impactful.
When branches of the trigeminal nerve are involved, lesions may appear on the face, inside the mouth, in the eye, or on the tongue. This can be particularly impactful due to the high sensitivity of these areas and their critical functions for sight, taste, and sensation. A specific and severe manifestation, often quite traumatic, is Ramsay-Hunt syndrome.
Ramsay-Hunt. Go.
In this condition, pain and vesicles appear in the external auditory canal, meaning inside or around the ear. Patients also experience a loss of their sense of taste in the anterior two-thirds of the tongue and develop ipsilateral facial palsy.
Paralysis on the same side of the face?
Yes, weakness or paralysis on the same side of the face as the ear pain. This complex syndrome specifically involves the geniculate ganglion of the sensory branch of the facial nerve, highlighting the direct and often debilitating neurological involvement.
Moving on to the complications of herpes zoster, what's considered the most debilitating one? And what is its long-term impact on patients?
In both normal and immunocompromised hosts, the most debilitating complication of herpes zoster is the persistent pain associated with acute neuritis and, even more so, postherpetic neuralgia, or PHN.
PHN, the lingering pain.
Exactly. PHN is uncommon in young individuals, but it's a significant burden for older adults. Alarmingly, at least 50% of patients over age 50 report some degree of pain in the involved dermatome that can persist for months or even years after the visible skin lesions have resolved.
Months or years.
Yeah.
Wow.
This isn't just mild discomfort. It can be severe burning, stabbing, or aching pain, profoundly impacting quality of life, sleep, and daily activities. Alongside the pain, changes in sensation of the dermatome, such as numbness, tingling, or increased sensitivity to light touch, are also quite common.
Adding to the misery.
It really does, adding to the persistent discomfort and impact on quality of life.
Can shingles also lead to central nervous system involvement similar to chickenpox? And what are the more severe neurological manifestations we might see?
Yes, CNS involvement can follow localized herpes zoster, and it's important to be aware of. Many patients, even those without overt signs of meningeal irritation, can show laboratory evidence of CNS involvement, such as CSF pleocytosis, an increased cell count in their cerebrospinal fluid, and moderately elevated levels of CSF protein, indicating some level of inflammation. More overtly, symptomatic meningoencephalitis can occur, characterized by headache, fever, photophobia, stiff neck, meningitis, and vomiting. A rare but very serious manifestation of VZV's CNS involvement is granulomatous angiitis with contralateral hemiplegia.
Angiitis, inflammation of blood vessels.
Yes. In this condition, blood vessels in the brain become inflamed, leading to stroke-like symptoms and paralysis on the opposite side of the body from the brain lesion. This condition can be diagnosed by cerebral arteriography, which visualizes the affected blood vessels. Other neurologic manifestations that can occur include transverse myelitis, which is inflammation across a segment of the spinal cord with or without motor paralysis.
Serious neurological consequences, then.
Potentially, yes. These highlight the potential for severe and widespread neurological damage beyond just the skin.
How does the severity and course of herpes zoster compare in immunocompromised individuals versus those with healthy immune systems? Is it much worse?
Like chickenpox, herpes zoster is significantly more severe and protracted in immunocompromised individuals compared to immunocompetent hosts. In these patients, the skin lesions continue to form for more than 1 week, and complete scabbing is often not achieved until 3 weeks into the illness.
Takes much longer to heal.
Much longer, indicating a much more prolonged and active viral replication due to a weakened immune response. Patients with Hodgkin's disease and non-Hodgkin's lymphoma are at the greatest risk for progressive herpes zoster due to their severely compromised cellular immunity. Cutaneous dissemination.
The rash spreading beyond one nerve area.
Exactly, meaning the rash spreads broadly across the skin beyond a single dermatome, develops in approximately 40% of these patients. Among patients with cutaneous dissemination, the risk of visceral complications like pneumonitis, meningoencephalitis, hepatitis, and other serious systemic complications is increased by 5–10%. However, it's an important distinction that even in severely immunocompromised patients, disseminated zoster is rarely fatal.
Okay, so rarely fatal, which is some good news.
Some, yes. It offers a degree of hope compared to some other severe opportunistic infections.
And what about VZV infection in post-transplantation patients? They're often on heavy immunosuppression. This must be a particularly high-risk group.
These patients are indeed at a profoundly high risk of VZV infection, and the consequences can be severe. A significant 30% of all cases of post-transplantation VZV infection occur within 1 year of the transplant, with half of those cases occurring within 9 months, underscoring the immediate vulnerability after their immune system has been suppressed.
A huge risk early on.
Very high. A substantial 45% of these infected patients experience cutaneous or visceral dissemination, highlighting the aggressive nature of the infection in this population. The mortality rate in this situation is 10%, which is quite significant. Common sequelae or lingering issues are particularly frequent and severe. Postherpetic neuralgia, extensive scarring, and secondary bacterial superinfection are especially common in VZV infections occurring within 9 months of transplantation. Furthermore, among infected patients, concomitant graft versus host disease.
Where the transplant attacks the body.
Yes, exactly. Where the transplanted immune cells attack the recipient's tissues significantly increases the chance of dissemination and/or death, as it further compromises the immune system's ability to control the virus. This highlights why understanding the patient's immune status is absolutely critical when dealing with VZV infections, as it drastically alters the prognosis and required management, often demanding immediate and aggressive antiviral therapy.
This detailed look at VZV's manifestations and complications truly underscores the importance of precise diagnosis, especially given some of the mimics we discussed earlier. It's a reminder that even for conditions with classic symptoms, the body can throw curveballs, right? And that's when precise diagnostic tools become paramount. Let's delve into how VZV infections are diagnosed, starting with chickenpox. Is it usually straightforward, or are there lookalikes?
The diagnosis of chickenpox is usually not difficult, primarily due to its highly characteristic rash. The presence of those multi-stage lesions, maculopapules, vesicles, and scabs, all present simultaneously combined with a history of recent exposure, should lead to a prompt clinical diagnosis in most cases. However, you're right, there are several viral infections that can mimic chickenpox.
Making differential diagnosis crucial.
Absolutely, for accurate identification, especially in atypical presentations or unusual epidemiological contexts.
What are some of those key mimics that can be confused with chickenpox, and how do clinicians tell them apart?
One important mimic is disseminated HSV infection, especially in patients with underlying skin conditions like atopic dermatitis, where the herpes simplex virus can spread more widely across the skin. Other infections that can cause disseminated vesiculopapular lesions include certain Coxsackie virus infections, echovirus infection, or atypical measles. The key distinction often lies in the rash characteristics. These other rashes are more commonly morbilliform.
Meaning more blotchy, less blistery.
Exactly. More macular or papular, and often have a hemorrhagic component, rather than being strictly vesicular or vesiculopustular, like chickenpox. Rickettsial can also be confused with chickenpox, but it's easily distinguished by the detection of the classic herald spot at the site of the initial mite bite and the development of a more pronounced headache. Serologic testing is also useful. Our source also mentions monkeypox, which should be considered in travelers returning from endemic areas.
Travel history is key there.
Always. And of course, historically, smallpox was a concern. Its lesions are larger than chickenpox, and crucially, are all at the same stage of evolution at any given time.
Unlike chickenpox's multi-stage lesions.
Right. That difference in lesion synchronicity is a critical distinguishing factor.
And for herpes zoster, or shingles, how is that typically diagnosed? What are its particular mimics or diagnostic challenges?
For herpes zoster, the diagnosis is usually quite straightforward when the hallmark is present. Unilateral vesicular lesions in a dermatomal pattern, that nerve distribution.
That distinct pattern is usually a giveaway.
Typically, yes. This distinct distribution along a nerve pathway is usually quite indicative. However, a significant diagnostic challenge arises with the reported occurrence of shingles without a rash, that zoster sign herpetica. In these rare cases, patients experience the characteristic dermatomal pain, but no visible lesions, making diagnosis incredibly difficult. Similar to chickenpox, both HSV and Coxsackie virus infections can also cause dermatomal vesicular lesions, creating potential confusion.
So lab tests might be needed then?
Yes, especially if the classic VZV pattern isn't perfectly clear. In ambiguous cases, supportive diagnostic virology, such as fluorescent staining of skin scrapings with monoclonal antibodies, is immensely helpful in ensuring the proper diagnosis. It's particularly difficult in the prodromal stage, before the rash appears. The diagnosis may only be made after the lesions have erupted or, retrospectively, by serologic assessment, looking for a rise in VZV antibodies.
Once a suspicion is raised, how do we get definitive laboratory confirmation for VZV? What are the gold standards in the lab?
Unequivocal confirmation of VZV infection is possible through several highly reliable laboratory methods. Historically, one method was the isolation of VZV in susceptible tissue culture cell lines, where the virus is grown in a lab.
But that takes time, right?
It does, so it's less common for routine rapid diagnosis. Another definitive method is the demonstration of either seroconversion, meaning a change from negative to positive antibody status in the patient's blood, or a fourfold or greater rise in antibody titer between acute phase and convalescent phase serum specimens. However, the most preferred and widely used method today is the detection of VZV DNA by polymerase chain reaction, or PCR.
PCR again.
Yes, it has become the diagnostic method of choice due to its speed, high sensitivity, and specificity.
So PCR is the go-to. What kind of specimens can be used for PCR detection, and why is it so much more effective than older rapid methods?
For PCR, versatile specimens can be used, including vesicular fluid from the lesions themselves, blood, and even saliva.
Saliva too, okay.
Yes, making it quite adaptable, depending on the clinical situation. PCR technology for the detection of viral DNA in vesicular fluid is now widely available in many diagnostic laboratories, and has, as you noted, become the diagnostic method of choice. The reason it's preferred over older, quicker methods like the zinc smear is its vastly superior sensitivity and specificity.
Speaking of older methods, are there any rapid impressions that can be obtained even if they're less sensitive, like a quick check?
Yes, for a rapid but less sensitive impression, a zinc smear can be performed. This involves gently scraping the base of the skin lesions and then examining the cells under a microscope to demonstrate the presence of multinucleated giant cells. While these are characteristic of herpes virus infections, the sensitivity of this method is relatively low, approximately 60%.
So a negative doesn't rule it out.
Exactly. A negative result doesn't rule out VZV infection, and it's mainly used as a quick screening tool to support a clinical suspicion rather than for definitive diagnosis. Other antigen detection methods, such as direct immunofluorescent staining of cells from the lesion base or the detection of viral antigens by other assays like the immunoperoxidase assay, are also useful for rapid confirmation.
And finally, what serologic tools are available to assess a host's immune response to VZV, maybe to check for past infection or vaccination status?
For assessing the host's immune response and antibody status, which tells us if someone has been exposed or vaccinated, the most frequently employed serologic tools include the immunofluorescent detection of antibodies to VZV membrane antigens, known as the FAMA test, also immune adherence hemagglutination, and the enzyme-linked immunosorbent assay, or ELISA.
ELISA is pretty common.
Very common. The FAMA test and the ELISA appear to be the most sensitive among these serologic methods, making them reliable for determining VZV immunity. This comprehensive approach to diagnosis, moving from rapid clinical impressions to highly sensitive molecular and serological tests, truly reflects the advancements in modern medicine that ensure accurate patient management and guide public health decisions.
Now that we have a thorough understanding of how these viruses are diagnosed, let's turn our attention to the strategies for management. Starting with the medical treatment of chickenpox in immunologically normal hosts. What's the primary goal here?
The primary goal for managing chickenpox in an immunologically normal host, someone with a healthy immune system, is fundamentally directed toward the prevention of avoidable complications. Since the body's immune system is usually quite capable of clearing the virus, the focus is largely on supportive care, symptom relief, and preventing secondary issues.
Rather than aggressive antivirals in most cases.
Correct, rather than direct viral eradication in most typical uncomplicated cases.
So what does that supportive care and hygiene involve, particularly for managing that incredibly itchy rash?
Good hygiene is paramount. This includes daily bathing and soaks to keep the skin clean and reduce bacterial load. Secondary bacterial infection of the skin, which is a very common complication, can be largely avoided by two simple but effective measures. Trimming fingernails short to minimize skin damage from scratching.
Without scratching damage.
Exactly. And applying antipyretic or anti-itch drugs to reduce the urge to scratch. For actual itch relief, tepid water baths and wet compresses are generally considered more effective and soothing than drying lotions, which can sometimes irritate the skin further.
And there's that particularly crucial medication that must be strictly avoided in children with chickenpox with historical implications. Remind us what that is.
Absolutely, and this is a critical public health message. The administration of aspirin to children with chickenpox should be strictly avoided due to its strong and well-established association with the development of Ray's syndrome.
That serious liver and brain swelling condition.
Precisely. Ray's syndrome is a rare but severe and potentially fatal condition. This is why you'll often see warnings against aspirin for any pediatric viral illnesses, a direct result of these findings with chickenpox.
When is antiviral therapy actually recommended for chickenpox in otherwise healthy adolescents and adults, and what agents and dosing are typically used?
For adolescents and adults with chickenpox, antiviral therapy is recommended, but with a crucial timing caveat. It must be initiated early in the disease.
Into 24 hours.
Yes, specifically within 24 hours of the rash onset to provide significant benefit. The agents and dosing typically used for a duration of 5–7 days include acyclovir, administered at 800 milligrams by mouth 5 times daily. Valacyclovir at 1 gram 3 times daily, which is licensed for use in children and adolescents. Or famciclovir at 250 milligrams 3 times daily, which is recommended but not explicitly licensed for varicella itself.
And what about children under 12? Is antiviral therapy used for them routinely?
For children under 12 years of age, acyclovir therapy may be beneficial if initiated early, again within that critical 24-hour window from rash onset, at a dose of 20 millikilos every 6 hours. It's worth noting that the second-generation agents, valacyclovir and famciclovir, offer pharmacokinetic advantages over acyclovir.
Meaning they work better with fewer doses.
Essentially, yes. As described in Chapter 191 of our source material, they are absorbed and metabolized by the body more efficiently, allowing for less frequent dosing, which can significantly improve patient adherence to the medication regimen.
It's good to know there's a strong emphasis on symptom relief and preventing secondary issues, alongside targeted antiviral options for those who can benefit most. Now, let's move to the comprehensive treatment of herpes zoster, or shingles, which, as we've heard, can be much more debilitating. What kind of supportive care is recommended there?
For herpes zoster, supportive care focuses on managing the local skin lesions and pain. Aluminum acetate soaks can be both soothing and cleansing for the skin, helping with discomfort and lesion management. Beyond supportive local care, patients with herpes zoster significantly benefit from oral antiviral therapy. This benefit is evidenced by accelerated healing of lesions and, critically, a quicker resolution of zoster-associated pain.
Which is often the worst part for patients.
Often, yes. That pain can be the most distressing symptom.
Which antiviral agents are preferred for shingles, and what are their dosing advantages over older options like acyclovir?
While acyclovir can be used, typically at a dosage of 800 milligrams 5 times daily for 7–10 days, the newer agents, valacyclovir and famciclovir, have superior pharmacokinetics and pharmacodynamics.
Meaning they work better in the body.
Yes, they are absorbed and act more efficiently, leading to better drug levels and therapeutic effects with less frequent dosing. They should therefore be used preferentially. Famciclovir, which is a prodrug that converts to penciclovir in the body, is considered at least as effective as acyclovir and perhaps even more so. Its typical dose is 500 milligrams by mouth 3 times daily for 7 days. Valacyclovir, a prodrug of acyclovir, has been shown to accelerate both healing and the resolution of zoster-associated pain more promptly than acyclovir. Its dose is 1 gram by mouth 3 times daily for 5 to 7 days.
Fewer pills per day, then.
Exactly. The key advantage of both famciclovir and valacyclovir compared to acyclovir is their less frequent administration, which can significantly improve patient compliance with the medication regimen, making it easier for them to complete the full course of treatment. It's also worth noting that all 3 of these drugs are now widely available as generic products, increasing their accessibility.
How does treatment differ, and what are the specific considerations for severely immunocompromised hosts battling VZV, whether it's chickenpox or shingles in those patients?
In severely immunocompromised hosts, such as transplant recipients or patients with lymphoproliferative malignancies like Hodgkin's disease, both chickenpox and herpes zoster, including disseminated disease, should be treated aggressively and immediately.
No waiting around.
Absolutely not. At least at the outset, treatment should always begin with intravenous or IV acyclovir. The typical dose is 10 milligicalograms every 8 hours for 7 days. IV acyclovir is critical in this population because it effectively reduces the occurrence of visceral complications, which are much more likely and severe in these patients, often being life-threatening. However, it's important to understand that while it impacts systemic spread, it typically has no significant effect on the healing of skin lesions or the associated pain in these patients.
So pain management is still needed separately?
Often, yes. That may require additional management. For low-risk immunocompromised hosts, oral therapy with valacyclovir or famciclovir appears beneficial, offering a less invasive option. Additionally, if medically feasible, it is highly desirable to decrease any concomitant immunosuppressive treatment while administering 5 acyclovir.
Letting the patient's own immune system help out.
Exactly. Reducing the immunosuppression can significantly aid the patient's own immune system, if possible, in fighting off the virus.
What about managing specific severe complications like varicella pneumonia or that dangerous zoster ophthalmicus?
Yeah.
These sound like they require very specialized interventions.
They absolutely do. Varicella pneumonia, due to its potential severity, typically requires aggressive medical management, including ventilatory support to help the patient breathe, sometimes even mechanical ventilation. For zoster ophthalmicus, immediate referral to an ophthalmologist is crucial due to the direct risk of permanent eye damage and blindness.
Get an eye specialist involved right away.
Immediately. Therapy for this condition includes the administration of analgesics for severe pain and the use of atropine to manage certain eye symptoms. While acyclovir, valacyclovir, and famciclovir all accelerate healing of the lesions in the eye, decisions regarding the cautious use of corticosteroids in these cases should be made solely by the ophthalmologist.
Because steroids in the eye can be tricky.
Very tricky. Their use requires careful consideration due to potential side effects and the specific eye involvement.
And finally, a really challenging and often chronic complication for patients: the pain associated with acute neuritis and postherpetic neuralgia, PHN. How is that managed, given its often debilitating nature?
The management of acute neuritis and the postherpetic neuralgia, or PHN, can be particularly difficult and often requires a multifaceted approach, as it's a neuropathic pain. It involves the judicious use of analgesics, ranging from non-narcotics for milder pain to stronger narcotic derivatives for severe cases. Beyond traditional pain relievers, several other classes of drugs are reportedly beneficial for pain relief in these specific neuropathic pain conditions. These include gabapentin, pregabalin, amitriptyline hydrochloride, an antidepressant with pain-relieving properties.
Drugs that work on nerve pain specifically.
Correct. Also, lidocaine in patch form applied directly to the skin, and fluphenazine hydrochloride. These drugs work on different pain pathways and can be used individually or in combination to find the most effective relief for the patient.
What about glucocorticoid therapy, like prednisone, for localized herpes zoster and managing pain? Is that a common practice, using steroids?
A significant finding from one study showed that glucocorticoid therapy, like oral prednisone, administered early in the course of localized herpes zoster, significantly accelerated quality of life improvements.
Faster recovery.
Yes, improvements included a faster return to usual activity and the ability to stop using analgesic medications sooner. The specific oral prednisone regimen used in this study was 60 mg a day for days 1 to 7, tapering to 30 mg a day on days 8-14, and 15 mg a day on days 15-21. However, and this is important, this regimen is appropriate only for relatively healthy elderly persons who present with moderate or severe pain.
Not for everyone, then.
Definitely not. There are also important contraindications.
Right.
Patients with osteoporosis, diabetes mellitus, glycosuria, or hypertension may not be appropriate candidates for this therapy due to the potential for exacerbating these underlying conditions. And crucially, glucocorticoids should not be used without concomitant antiviral therapy.
Need the antiviral alongside it.
Absolutely, as steroids can potentially worsen viral replication if used alone, leading to more severe or disseminated disease. The nuance here, particularly with pain management and the cautious, individualized use of corticosteroids, highlights that even with common conditions, treatment is highly individualized and requires expert clinical judgment, weighing benefits against risks.
Beyond treatment, our source details 3 robust methods for preventing VZV infections, a testament to decades of public health advancements. Let's start with vaccination. What does our source tell us about the varicella or chickenpox vaccine and its impact?
The Varicella vaccine is a triumph of preventative medicine, really. It is a live attenuated vaccine.
Weakened live virus.
Yes, meaning it contains a weakened form of the live virus that stimulates a robust immune response without causing the full-blown disease. It is recommended for all children and for adults known to be seronegative for VZV, indicating they haven't had chickenpox or been vaccinated previously. For children, 2 doses are recommended, the first at 12-15 months of age and the second at approximately 4 to 6 years of age. For VZV seronegative persons over 13 years of age, they should receive 2 doses of the vaccine at least 1 month apart. The vaccine is both safe and highly efficacious, having significantly reduced the burden of chickenpox in vaccinated populations.
It really changed the landscape, didn't it?
Dramatically. Even if breakthrough cases occur, meaning someone gets chickenpox despite being vaccinated, they are typically mild and may result in the spread of the vaccine virus, which itself is a less virulent form, to susceptible contacts. The widespread, universal vaccination of children has, as expected, resulted in a dramatic decrease in the incidence of chickenpox in sentinel communities, fundamentally changing its epidemiology. Furthermore, an interesting additional benefit is that inactivation of the vaccine virus significantly decreases the occurrence of herpes zoster after hematopoietic stem cell transplantation in high-risk individuals.
So it helps prevent shingles later, too, in some cases.
It shows an additional protective effect on future shingles risk in that specific high-risk population.
And what about the vaccine for herpes zoster, or shingles? That's a huge advancement for older adults, given the debilitating nature of shingles and PHN.
It truly is a remarkable advancement that has transformed the landscape for older adults. In individuals over 50 years of age in the United States, the current shingles vaccine of choice is Shingrix. It's a subunit vaccine, which is distinct from the live attenuated varicella vaccine. Shingrix consists of VZV glycoprotein E.
Just a piece of the virus.
Exactly. A specific viral protein necessary for infection combined with the AS01B adjuvant, an ingredient that significantly boosts the immune response, making it very powerful. A pivotal randomized placebo-controlled study demonstrated its remarkable efficacy. This study involved administering 2 doses of vaccine or placebo 1 month apart to over 15,000 participants aged 50 years or older. The results were truly impressive. The overall vaccine efficacy for the prevention of herpes zoster was an astounding 97.2%.
97.2%. That's incredible.
It is, with a very narrow 95% confidence interval of 93.7, 99.0%, and a statistically significant p-value of less than 0.001. That's an incredibly high level of protection.
That sounds incredibly effective. 97.2%. But were there many adverse events with the shingles vaccine? Or perhaps any common misconceptions about it we should clear up?
Well, while injection site and systemic reactions such as pain at the injection site, fever, or muscle aches were more frequent in vaccine recipients compared to the placebo group, these were generally mild to moderate and transient, just lasted a day or two for most.
So temporary side effects.
Mostly, yes. Critically, the proportions of participants who had serious adverse events were similar in both the vaccine and placebo groups, indicating a favorable safety profile despite the common transient reactions. Because of this high efficacy and acceptable safety profile, the Advisory Committee on Immunization Practices, or ACP, has strongly recommended that persons in this age group be offered this vaccine to significantly reduce both the frequency of shingles and the severity of postherpetic neuralgia.
So misconception 1, you should get it even if you had chickenpox.
Absolutely. Everyone who has had chickenpox should get the shingles vaccine, as it boosts the waning immunity that prevents reactivation. That natural immunity fades over time.
And misconception 2, it's not 100%.
Correct. While 97.2% is incredibly high, it's not absolute protection for every single person. Of note, vaccine immunity, like many vaccines, does wane over time, and our source mentions that reassessment of current recommendations or the use of a promising inactivated vaccine in development will be required in the future.
To maintain that protection long term.
Exactly, to maintain optimal, lifelong protection. What's truly fascinating here is how successful vaccination has been in transforming the epidemiology of VZV, moving it from a widespread, often severe childhood disease and a debilitating later life condition to a largely preventable illness, particularly for the elderly.
That's incredible progress. So beyond vaccines, what's the second primary method our source outlines for VZV prevention, particularly for those who haven't been vaccinated or are at high risk after an exposure?
The second robust approach is the administration of Varicella-Zoster immunoglobulin, or VZIG.
Immune globulin, so giving antibodies directly.
Precisely. This is a passive immunization strategy, meaning it's a product that contains preformed antibodies against VZV, providing immediate, albeit temporary, protection. Its purpose is to be administered to specific individuals who are susceptible to varicella, are at high risk for developing severe complications if they contract varicella, and have had a significant exposure to the virus. VZIG should be given as soon as possible, ideally within 96 hours, and preferably within 72 hours of the exposure. However, importantly, it may still be administered up to 10 days with similar efficacy.
So there's a bit of a window.
Yes, providing a crucial window for intervention, particularly for vulnerable individuals.
Who are the specific individuals considered candidates for VZIG? And what exactly qualifies as a significant exposure? This sounds like a very targeted intervention.
You're right, it is highly targeted. Our source provides a detailed table on the indications for VZIG administration. For exposure criteria, one of these must apply. Living in the same household as an infected person, having face-to-face indoor play with an infected person, or specific hospital exposures like being in the same 2 to 4 bedroom, adjacent beds in a large ward, face-to-face contact with an infectious staff member or patient, or a visit by a contagious person. For zoster exposure in a hospital, it's defined as intimate contact, like touching or hugging with a contagious person. Also, a critical scenario for a newborn infant is when the onset of varicella occurs in the mother within 5 days before delivery or within 48 hours after delivery.
That dangerous perinatal window again.
Exactly. Importantly, VZIG is not indicated if the mother has zoster, as the risk profile for the newborn is different in that scenario.
And who are the specific high-risk patient populations who are the primary candidates for VZIG, assuming they meet those significant exposure criteria?
The primary candidates who receive this critical protective measure are, first, immunocompromised susceptible children who have no history of varicella or varicella immunization. Their weakened immune systems make them highly vulnerable. Second, susceptible pregnant women, given the severe risks of perinatal varicella. Third, newborn infants whose mother had onset of chickenpox within that dangerous window of 5 days before or 48 hours after delivery. Fourth, hospitalized premature infants born at 28 weeks of gestation or more, and whose mother lacks a reliable history of chickenpox or serologic evidence of protection against varicella. And fifth, hospitalized premature infants born at less than 28 weeks of gestation or weighing 1,000 grams or less at birth, regardless of their mother's history of varicella or VZV serologic status.
Very specific groups.
Extremely specific. These criteria highlight the specific, highly vulnerable populations for whom this prophylactic measure is critical because their nascent or compromised immune systems simply cannot mount an adequate defense.
So, between the powerful vaccines, the targeted immune globulin, what is the third prevention method outlined in our source for VZV? It truly underscores how multifaceted viral control has become.
Lastly, we have antiviral prophylaxis.
Using the antiviral drugs preventatively.
Exactly. This approach involves using antiviral medications prophylactically, meaning to prevent an infection from taking hold or becoming severe after exposure. This strategy is primarily used for individuals at high risk who are either ineligible for vaccination or who are beyond that critical 96-hour window after direct contact when VZIG would be most effective. While initial studies on this prophylaxis uses ciclovir, similar benefit can now be anticipated with either valaciclovir or famciclovir.
The newer agents again.
Yes, offering more convenient dosing schedules for these high-risk individuals. It's about having a full range of tools and strategies to protect those most vulnerable when direct exposure occurs, ensuring multiple lines of defense.
What an incredible journey we've taken today. From understanding the broad, nuanced challenges of herpes simplex virus control at a population level, to dissecting the intricate life cycle of Varicella-Zoster virus, its varied manifestations as chickenpox and shingles, and then delving into the sophisticated ways we diagnose, treat, and prevent it, we've truly taken a deep dive into Chapter 193, Varicella-Zoster virus infections, and the broader field of viral management.
We hope this deep dive has offered you not just a comprehensive understanding, but maybe a new perspective, connecting the intricate cellular details to the bigger picture of public health and individual well-being. Knowing the why behind these common infections profoundly changes how we perceive them and highlights the ongoing complex battle against viral diseases. It's not just about memorizing facts, but about seeing the interconnect.
Indeed. Considering how sophisticated our strategies for managing and preventing these viruses have become, what do you think is the next frontier in viral defense? Is it about tailoring treatments more precisely to individual immune systems? Perhaps even designing vaccines that offer truly lifelong universal protection? Or could it be about even broader societal changes to reduce transmission in novel, perhaps more integrated ways? Something to mull over as you reflect on the remarkable complexities of these microscopic foes until our next deep dive.